So good morning, everybody. I welcome you to our Meet the Expert session, Bleeding Management in Postpartum Hemorrhage. So since the time is limited, we start immediately. And I would like to introduce our expert speaker. It's Dr. Ramani Pallemulle. She's a senior consultant, anesthetist and intensivist at Castle Street Hospital for Women in Colombo, Sri Lanka. Her focus of interest is obstetric hemorrhage and obstetric critical care. And she was also the head of the Committee of Obstetric Anesthesists in the College of Anesthesiologists and Intensivists of Sri Lanka for 5 years, is a member of the Multidisciplinary Guideline Development Committee on Postpartum Hemorrhage in Sri Lanka. And in summary, she did a great job in reducing maternal mortality and to achieve the WHO Millennium Goal 5 in Sri Lanka. My name is Klaus Görlinger. I'm from Munich in Germany. And yeah, we will start immediately with the presentation. So please, Dr. Ramani, share your screen. And at the end of the presentation, we have the possibility to have a short discussion. For this, you can just raise your hand and we do the discussion directly, or you can also in between send some questions by chat. So Dr. Ramani, the floor is yours.
Hello everybody. Thank you, Dr. Görlinger, for your kind introduction. My focus today is mainly on optimal use of thromboelastometry in postpartum hemorrhage. These are the main points I hope to discuss today. I'm going to use Sri Lankan data and practices for this purpose. Obstetric hemorrhage has always remained among the top 3 causes of maternal death. There hasn't been any significant reduction of deaths over the last 10 years. Importantly, around 60% of the deaths had been preventable almost every year. In the 3-delay model of maternal deaths, 49% had been due to delays in receiving care. This highlights the need to focus more on hospital management. Not only mortality, maternal severe morbidity too has been significantly caused by obstetric hemorrhage, amounting to 41% of total cases. There are several quality improvement tools already introduced in Sri Lanka for improving care, such as track trigger response systems, care bundles, guidelines, etc. However, there is always room for improvement. One such area is types and timing of blood product transfusion. Of course, there could be controversies and doubts among clinicians in this regard. It is essential to correct coagulopathy using required blood products at correct time. The risk factor to drop precipitously is fibrinogen due to loss, dilution, deactivation at an early stage, and consumption in later in most cases. Fibrinogen is an early biomarker with a positive predictive value of 100% for progression into severe hemorrhage when it is less than 2 grams per liter. So, therefore, what is the rational treatment? By correcting low fibrinogen levels early, progression into severe hemorrhage can be prevented, provided the surgical bleeding is controlled adequately. It is important not to let fibrinogen drop any further by avoiding large volumes of crystalloids and the use of unnecessary blood products containing little or no fibrinogen, such as FFP and platelets. Currently, only viscoelastic tests have the ability to analyze dynamic changes of fibrinogen with minimum time outcomes. FibTem-A5 of Rotem gives results in 5 minutes, graphically and numerically. Therefore, point of care thromboelastometry is of immense help in managing severe postpartum hemorrhage. These are the methods used in current practice to replace blood components. Shock packs, early targeted therapy using point-of-care thromboelastometry, and shock packs combining with thromboelastometry. TEM-guided coagulation factor replacement is recommended by NATA consensus statement and RCOG as well. And it is also recommended in Sri Lanka by Sri Lanka College of Obstetricians and Gynecologists and College of Anesthesiologists and Intensivists of Sri Lanka. A retrospective single center study carried out at Castle Street Hospital comparing shock packs with early targeted treatment using point-of-care thromboelastometry also confirmed benefits of early targeted therapy. There was a significant reduction in FFP and platelet transfusions, together with overall reduction in blood volumes, the total volumes transfused. Problem with large volume transfusion is circulatory overload. So in UK, more than 50% of deaths associated with transfusion was caused by TACO, that is transfusion-associated circulatory overload. We also found that 32% with severe hemorrhage did not require any blood product. This indicates that shock pack treatment is unnecessary and could be avoided in significant proportion of patients. Hysterectomy rate, complications such as TACO, ICU stay, and overall cost were all reduced significantly. However, total blood loss and amount of blood transfused were not significantly different. This was thought to be due to the study group mainly consisting of placenta accreta spectrum disorders, in which rapid severe bleeding needs rapid blood transfusion to maintain cardiovascular stability. Our current situation is even better, maybe because of experience gained with the TEM-based management over a long period. 80% of cases are done under regional anesthesia. 100% TEM-guided blood product transfusion is carried out. Hysterectomy rate is very low, which is a key marker of improved morbidity, according to Embrace UK. Low hysterectomy rate has been achieved with improvement in both surgical and medical management. Although ROTEM is widely available all over the country, only 16% of them have been installed at point of care. The rest is installed at blood banks and hematology labs. Unlike Castle Street Hospital, we found that all the other hospitals initiate blood product replacement with shock packs, irrespective of the availability of the ROTEM at point of care. Transfusion specialist advice is usually obtained after initiating shock packs, and management is followed accordingly with or without ROTEM tests. So by now, it is evident that if used optimally, TEM can contribute to improved outcomes. For optimal use of thromboelastometry, it should be available at point of care, meaning operating theatre or the ICU. Decision maker may be the consultant anesthetist or the transfusion specialist, has to be physically present in OT so that ongoing clinical condition can be taken into account for decision making. Most useful tests are the XTEM-A5 and XTEM-CT and A5. ML-XTEM within 60 minutes is used to assess fibrinolysis after initial treatment with tranexamic acid. First sample of blood taken around 100,000 of 1000 ml of blood loss. Blood products given only according to TEM reports from the beginning. Only validated pregnancy-specific algorithm and dose calculation chart is used. Adequate replacement confirmed with thromboelastometry may need to repeat the tests according to individual cases. Platelet functions and other TEM tests rarely needed, for which transfusion specialist or hematologist advice is obtained. My recommendation is that it is high time now to think about a change in traditional practice. When thromboelastometry is available at point of care, optimal use of TEM is recommended. discourage late use as the benefits of TEM will be undermined. Everyone in the team should be very clear about the timing of thromboelastometry in their local protocol. Anesthetist is the most suitable clinician for initiation of TEM-guided transfusion. When TEM is not available at point of care, shock packs with inclusion of cryoprecipitate from outset can be suggested. Platelet transfusion is recommended when the count is less than 75,000 per cubic millimeter. Thank you.
Much, Dr. Ramani. So we have now the floor open for discussion. Up to now, I didn't see questions in the chat, so we can just see what are questions directly from the participants. So if you have a question, just unmute and then we can communicate this directly. If there's not a burning question up to now, maybe one question as a starter from my side. So what do you think, Dr. Ramani, what is the importance in postpartum hemorrhage, having this information about coagulation available in a short time?
Yeah, now as I discussed in my presentation, when it is available immediately, the degree of the coagulopathy or the factor levels in blood, it is very, very easy for us to decide on which factor to be given, avoiding unnecessary blood product transfusion. So that is the main the significance of this availability of point of care ROTEM facility in your hospital. So my worry is actually when it is available, even available at point of care, our clinicians are a bit reluctant to start with the ROTEM guided. You know, they are always happy with the massive transfusion protocol. They start with that and later go for the to see whether they have corrected the coagulopathy. That is the thing I can see. So there could be delays in correcting coagulation. So that way, I think the patient may bleed more and more morbidity can be, you know, may be due to that. So that is why I think this early point of care TEM application is important in the management of postpartum hemorrhage. And then it is not difficult. That's what I have to say. It's very easy. When you have the algorithm with you, the validated algorithm specific for the pregnant patient. Sometimes I noted general algorithms have been used, not the pregnancy specific one. So I would like to say the pregnancy specific algorithm should be used, and these are validated algorithms and those calculation charts are available. So then we can manage the patient easily and prevent the patient going into, you know, DIC situation.
Now we have one question. Oh, sorry. I didn't want to interrupt you. I just saw that we have now also some questions in the chat. The first is from Dr. Stanley Igwe. I hope I pronounced in the right way. It's about that the fibrinogen, he's from Nigeria, that fibrinogen is not available in Nigeria, and most hospitals don't have a TEC or ROTEM in their facility. So how can one effectively use blood products to manage PPH? I think the question is also going in the direction, what blood products should we use? Fresh frozen plasma or cryo? In particular, if fibrinogen concentrate is not available in postpartum hemorrhage. Yeah,
the fibrinogen concentrate is actually not freely available to us also in Sri Lanka. So what we, it's available, I mean, very limited amount is available to us, but we have cryoprecipitate. So when the cryoprecipitate has about 20 times more fibrinogen in it compared to FFP. The problem with FFP is it has less fibrinogen. So when the fibrinogen levels are depleted, by giving FFP, we may dilute. That is why the dilution coagulopathy develops, and then you give more and more volumes of FFP, then leading to the circulatory overload and all the related issues. So cryoprecipitate is very useful in this regard, and which is available. I think it's not that expensive also, like when compared to fibrinogen. So, but when the thromboelastometry facility is not available, then it's difficult to go by the traditional, the conventional tests like INR, APTT. It's time taking. By the time we get the result, the reports, it is not valid to correct the hemorrhage at that situation, at that time. So therefore, actually, I think because in most of the patients, this the problem is the drop in fibrinogen, serum fibrinogen level. So it is rational to start cryoprecipitate early, rather than just going into this 1:1:1 the regime of blood, 1 unit blood, then 1 FFP, 1 platelet. We can correct the coagulation problem by using cryoprecipitate early, maybe 10 or 20 units with the blood loss of exceeding when you give more than say 3 or 4 units of blood transfusion. That is the time to start. But however, in studies, including ours, have shown that about 30, in some studies even more, about 70% of these patients who develop severe postpartum hemorrhage don't need any blood products. What you need is replacement of blood only. So that is there, but since with the unavailability of the point of care testing, I would suggest you could start with cryoprecipitate without any fear, and that would help you to manage the coagulation part without going into a massive hemorrhage and massive transfusion level.
Yeah, thank you. So there's another question going maybe in the similar direction. I'm not aware exactly where it's coming from, but let's say our unit is smallish, only 4,000 to 5,000 deliveries per year. I can say for Germany, this is a big one. For Colombo, it's maybe a small one. But they discuss, or the question is about the cost effectiveness to buy a rotor machine, if that works even with 4,000 to 5,000 deliveries. And they say that they don't have a big other kind of surgeries. Maybe I can just add one point in the beginning. There was a nice health technology assessment in the UK where they're speaking about that if you have 20 to 30 severe bleeding patients per year, more or less the system is cost effective. But of course, that depends on also the local situation, local cost blood products. What is your opinion, Dr. Ramani?
Yeah, I think I agree with you, Dr. Gerlinger, because you have the thing is now what we have is this Rotem Delta machine. So where the consumables also becomes an issue when if you don't have many cases, because once you open these vials, then you can keep that only for 10 days or so. So then again there could be a wastage. So then you need more and more patients on whom you can do this testing. But with, I think the Sigma machine, there the cartridge system is available, and there I think you could save on. I think, because I don't have any experience with that, what I have heard is that. But to have a Rotem machine is, it's an asset. It's a very valuable piece of equipment to have in places where so many pregnant mothers are managed, in especially women's hospital. I would suggest, and in hospitals where so many patients are being managed. The thing is, to use it optimally, as I described, you need to have it at point of care as well. Having it in a distant place and taking time to send samples there and then get the report is a bit of, then you have to use it a bit late. So that problem is also there. Yes, so it could be a problem, but as you say, Dr. Gallinger says 30 to 40%, isn't it? So the patients turn over, then of course I think it will be very cost effective.
Yeah, where we have time for a last question. This is about the early use of tranexamic acid. Would you recommend to give tranexamic acid early? And in case of fibrinogen not available, maybe I can add, is tranexamic acid replacing fibrinogen, or is that an additional intervention, which is of course maybe important?
I think now, according to this woman's trial, now it has shown reduction, very significant reduction in mortality by giving tranexamic acid very early in the management of postpartum hemorrhage. And in fact, now there are recommendations to give it prophylactically when you anticipate a massive hemorrhage. So I think the giving tranexamic acid is very, very important, whether you have the Rotem facility or not. That is one of the essential steps in the management of postpartum hemorrhage, to give tranexamic acid 1 gram and then repeat it after 20 minutes or so if there is ongoing bleeding. And I don't think the correction of fibrinogen is different. I think it's both are not interconnected. I think it is very, very important according to guidelines also. Giving tranexamic acid, you shouldn't wait for Rotem reports. You shouldn't wait for fibrinogen levels available or anything. It is very important to give it, even without having the fibrinogen correction. Yeah.
Yeah, thank you very much. So I think we are at the end of the short time which had available for the Meet the Expert session. Thank you very much, Dr. Ramani. Thank you to all the participants. I think it's also possible to put some additional questions in the chat, and we try to answer them later on. And I also wish you a nice Congress, and hope that maybe next year it would be possible again to meet in person. In particular, I think for these direct discussions, it's nice that we can do it by chat, but even I think it's even more nicer if we can do something like this face to face. So yes. Thank you again to everybody, and yeah.
Thank you everybody. Bye bye.